Welcome everyone to the Ontario Caregiver Organization's webinar series. These webinars bring together caregivers and subject matter experts to explore topics of interest to caregivers. And we do this to support and engage chosen family, friends, neighbors, really anyone who is caring for someone else. My name is Katie Muirhead, and I am going to be your moderator for today. And before we begin, I'd like to take a moment to acknowledge the lands that we're on today. While we meet on a virtual platform with folks joining us from across the province, I'd like to take a moment to acknowledge the importance of the land we each call home. I'm joining you today from the city of St. Catharines in the Niagara region, which is the traditional territory of the Haudenosaunee and Anishinaabe peoples. This territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging this reminds us that our great standard of living is directly related to the resources and friendships of Indigenous peoples. If you'd like to learn more about the lands where you're joining from, you can find more information at native-land.ca. So our webinar today is called High Quality Care for People with Chronic Obstructive Pulmonary Disease, or COPD. Quality standards are important for patients and their caregivers to know what to expect in their care. Caregivers of individuals with chronic obstructive pulmonary disease need to have access to information, tools, and resources to help manage the challenges associated with COPD. In recognition of COPD Awareness Month, which is November, we are here today to tell you a little bit more about the updated Ontario Health COPD Quality Standard and the Patient Guide. Key quality statements that can enhance care for people with COPD and their caregivers in the community. We're also going to share more about programs, tools, and resources for caregivers. And we're going to hear some caregiver experiences through our talk today as well. So I'd like to introduce you to Gracia Mabaya, who is going to kick things off today. Gracia is the lead in the Clinical and Quality Standards program at Ontario Health. She's been with Ontario Health for close to 8 years and has spearheaded and contributed to the development and refinement of quality standards across various health conditions, including the recent update we're discussing today of the COPD care in the community for adults quality standard. So I'm going to turn it over to you, Gracia, to get us started.
Thank you so much, Katie, for that great introduction, and welcome everyone. It's a pleasure to be here today and to present on high quality care for people with COPD. And I think today is also COPD Awareness Day, so it's perfect timing for this webinar. So today we'll hear some lived experience stories from one of our panelists, and we'll also go over some Ontario data highlighting why a quality standard was needed for COPD. We'll give you a brief overview of the COPD quality standard and highlight some key resources for care partners or caregivers, as well as implementation efforts. And then we will go into our question and answer period. And so as it was mentioned earlier, if you have any questions, feel free to put them in the chat. And when we get to that time, we will answer your questions. So I would like to introduce our speakers. So we have Myra Stephen, who has been retired for just over a year from a career in education. She worked as a teacher in Toronto and in Japan as a curriculum consultant, vice principal, and most recently at the Ministry of Education, where her focus was on curriculum development, well-being, inclusion, mental health, and support for new teachers. A defining part of who Myra is comes from the time she spent with her mom in the last 2 years of her mother's life when she was living with Alzheimer's. Myra worked with her mom to find joy in that journey and learned lots about making connections in the healthcare system to find the supports that benefited her mom, the family, and caregivers. While Myra is figuring out what retirement looks like, she's enjoying contributing to organizations working towards more family and patient-centered care. She hangs her hat in both rural Ontario, the village of Haliburton, and in the city in Toronto. So we'll hear from Myra very shortly, and thank you for joining us today. The second speaker I would like to introduce is Ellen Fleming Michaud. She's a registered respiratory therapist and certified respiratory educator with over 20 years of experience in both acute, critical, and primary care settings. Ellen is passionate about lung health and a strong advocate for her clients. Ellen has diverse background and has provided asthma and COPD education, spirometry testing, smoking cessation, counseling, and pulmonary rehab maintenance services to patients living in rural, remote areas of Renfrew County. Ellen is currently the interim lung health coordinator with Connect Well Community Health. Although she's currently not participating in direct patient care, she brings her years of experience, wealth of knowledge, and passion to mentor her colleagues while working on expanding the program. Welcome, Ellen, and looking forward to also hearing from you as we go through the specific quality statements within the quality standard. And the third speaker I'd like to introduce today is my colleague, Julie Skelding. She's the lead clinical programs innovation and research at Ontario Health and a master's prepared nurse with experience in quality improvement, change management, and most recently, the implementation of a province-wide COPD initiative. Julie's clinical experience in primary care, mental health, and sleep medicine gives her a deep understanding of healthcare services to improve patient care and support staff in change management to enable system transformation. And welcome, Julie. Looking forward to hearing from you soon as well. So next, I will now give over the floor to Myra, who will share her lived experience story with us. Myra, if you can please come on.
Thank you very much, Gracia. I'm really glad to be able to be here today and share a little bit of my story. And if you want to go to the next slide, there we go. I like seeing my mom's face when I'm talking about her. So my mom was experiencing some breathlessness when exerting herself and was diagnosed with COPD in her late 70s. She was fit and active, but she had been a smoker for many years. She started in her early 20s and smoked until she retired. She was diagnosed with COPD, and her family doctor referred her to a clinic at the local hospital. And she learned about taking the Spiriva medication with an inhaler and about overall management and care. Her condition was well managed by her doctor and by herself, and she remained active. She loved walking, but generally tried to avoid walks that involved big hills. Towards the end of the COVID pandemic, my mom developed Alzheimer's. She was 85 years old. And so for the last 2 years of her life, my sisters and I and other caregivers lived with her in her home to support her to live fully. She loved being physically active. Being outside in nature was her happy place. But as her disease progressed, she needed more support. To help with balance and stability, she used walking poles or held our hands, and we purchased a small stool that we would carry with us as we walked so that she could take breaks whenever she needed to. As her dementia progressed, she needed support to take her medication. My mom had a great sense of humor, so we made a bit of a game, saying all the steps out loud. Flip, turn, blow out, snort in, and hold. It was a lot of steps to remember. She called her Spiriva her snort. Her sense of humor and her dementia made it a little bit tricky sometimes. She thought it was funny to release the medication into the air or to be a dragon and blow the medication out of her nose instead of inhaling it. So we danced a bit of a fine line sometimes, working to get the medication inside of her while also trying to keep the experience positive. I didn't know about the quality care standards, but as I look at them in retrospect, I believe that for the most part, in my mom's case, the standards were met. One of the standards that made a significant difference for her and also for me as a caregiver was quality statement number 8, the specialized respiratory care, which is basically about getting the specialized care that you need when you need it. I'll just give you a second to read that. So that specialized care made a real difference for my mom and I when she and I both developed COVID-19 in late September 2022. We tested positive on a Friday afternoon, and my mom was experiencing significant symptoms with shortness of breath, which was frightening for her because she didn't understand it, and also frightening for me as a caregiver. Her family doctor quickly provided or prescribed Paxlovid and also made a referral to ProResp, which was an organization locally who could provide oxygen and also consultation in the home if needed to try to keep people out of the hospital during the pandemic. It was a real comfort to me to have access to that service if needed, especially since she was diagnosed on a Friday. So we had help over the weekend if we needed it. We ended up not having to give her any oxygen or having anyone come in, but just knowing that I could call them really made a difference to me. While my mom got good care from her family doctor and from the team of medical professionals who supported her Alzheimer's, I realized in retrospect that I didn't really know a lot about her COPD and the risks and effective management. I went with my mom to all of her doctor's appointments in the last few years of her life. And I think if I was aware of the quality standards, I may have asked more questions. The quality statement number 4 about, excuse me, education and self-management is about getting information and about management of the care. As my mom's power of attorney for personal care, I think in retrospect, it would have been good for me to have been more aware of the condition and the care plan related to my mom's COPD. At the end of her life, my mom was admitted to hospital with symptoms likely related to her COPD. She had fluid on her lungs and also heart failure and was having trouble breathing, and again was scared about that. When in the hospital for about 2 weeks, at once a nurse brought her Spiriva to administer, but the rest of the time she didn't take it when in the hospital. Knowing about the quality standards and her care plan related to COPD might have helped me in terms of knowing what to expect when in the hospital. But hindsight is always 20/20. Overall, I'm glad to know that my mom got the care that she needed, both from her healthcare team and from the family. And I'm glad to know that this information and the resources are available to help people who are caring for someone with COPD.
Thank you so much, Myra, for sharing that very inspiring, those lived experience stories that you've shared are really helpful, and the images really bring to life the different stories that you've shared and the memories of your mother that you carry on. And I'm pretty sure that the caregivers on the call are very grateful to hear from you. And thanks for all the great work that you're doing. And we'll hear from you a bit later when we go into question and answer for anyone who has specific questions for you. Thank you so much. So now I would like to speak about some data behind why this quality standard on COPD was developed and why it's really important. So worldwide, we know that COPD is a leading cause of morbidity and mortality, and it results in social and economic burdens that are very substantial and increasing. And although smoking rates are declining in Ontario, we know that COPD is still one of the most common chronic conditions. And in Ontario, the overall estimated prevalence of physician-diagnosed COPD among adults who are 40 years and older is about 10.5%, which means that about 1 in 10 people in Ontario have COPD. And the highest prevalence of COPD in Ontario in the year 2021-2022 was in the Northeast region, which is at about 16%. Also, in the same fiscal year, 2021-2022, only about 40% of people with COPD received spirometry testing to confirm their diagnosis. And this number is down from 45% in fiscal year 2016-2017. In 2021-2022, the proportion of people diagnosed with COPD who received spirometry testing in Ontario varied from about 26.9% in the Northwest region to about 42.5% among those in the West region. So we see that there is some variation in what is going on across Ontario in different regions as well. And people living in lower income neighborhoods have the lowest rates of spirometry testing and experience the greatest decrease in testing from the year 2016-2017 to 2021-2022. So the impact of the COVID-19 pandemic on healthcare utilization was greatest among people with COPD living in the lowest income quintile neighborhoods, they experienced about a 7 percentage point decrease in spirometry testing compared to a 2 percentage point decrease among those in the highest income quintile neighborhoods. So we see that there's also variation in spirometry testing based on income levels and the different neighborhoods. And so spirometry testing to diagnose, to confirm a diagnosis of COPD will be covered as we go through the specific quality statements. So now I would like to introduce the COPD quality standard. And so quality standard, if anyone is unfamiliar with Ontario Health quality standards, basically they consist of a small set of high impact statements describing optimal care for a given health condition or a process of care. For example, we have quality standards on diabetes, schizophrenia, or transitions between hospital and home. And to date, our quality standards library has about more than 38 quality standards. And so they focus on conditions or processes where Ontario data shows that there are large variations in how care is delivered across the province, or where we see gaps between the care that is provided and the care that patients should be receiving. And quality standards are also grounded in the best available evidence. So we use clinical practice guidelines, as well as the clinical expertise and lived experience of our advisory committee members. And so in short, they set a standard for how care should be delivered, no matter who provides the care or where the person lives in Ontario. And so each quality standard is developed with a suite of resources. And so these resources include a patient guide to support patients, family members, and care partners in terms of assuring that they receive the care that they need, that they ask the appropriate questions, and that they have access to key resources. We also have some implementation supports, which include a getting started guide for organizations, a measurement guide, as well as technical specifications and data tables for the indicators within the quality standard. And there is also a clinician resource, which is a placemat that they can use within their clinic as they're providing care, which is basically a high-level summary of the quality standard itself. To develop this quality standard, Ontario Health recruited an advisory committee made up of clinical experts from across Ontario to advise on what the quality standard would include, as well as people with lived experience. So this advisory committee also included 3 people with lived experience and care partners whose names are listed on the slide here. And there's also a QR code that you can scan to access the website directly. The COPD quality standard addresses care for people with COPD, including the assessment of people who may have COPD, and it really provides guidance on the diagnosis, management, and treatment of COPD within community-based settings, applying to primary care, specialist care, and long-term care and other home and community care settings. It doesn't specifically address care provided in an emergency department or hospital inpatient setting for the management of acute exacerbations of COPD. And so these are the topic areas that were prioritized by the advisory committee, highlighting key areas where there's a need for improvement in COPD care in Ontario. There are 14 of them, and so we will touch on a few of them during this presentation, but we invite you to consult the quality standard as well as the patient guide to get more information on some of the ones that we may not cover in this presentation, just in the interest of time. So now we're going to take a deeper dive into the quality statements and what they mean for patients and care partners or caregivers. We're also going to highlight some tools and resources that can make it easier for care partners to better support their care recipient in managing their COPD. Some of the tools and resources may not be highlighted within this presentation, but once you receive the slide deck, there will be an appendix that includes additional resources for you to access. And so at this time, I would also like to invite Ellen, if she can come on, as her and I will be covering this section together.
Hi, everyone. Thanks for having me join today.
Thanks, Ellen. So the first statement we want to dive into is statement number 1, which is diagnosis confirmed with spirometry, something that the data really highlighted. So it says that people clinically suspected of having COPD have spirometry testing to confirm diagnosis within 3 months of developing respiratory symptoms. And so what this means for you or the person that you're caring for is that if you have respiratory symptoms that do not go away, your healthcare professional should talk with you about having a breathing test, which is called spirometry, also called a lung function test or pulmonary function test. And so this test is really done to confirm whether you have COPD. Spirometry determines if there is an airflow blockage in the lungs, and if there is a blockage, how severe it is. And so, Ellen, I want you to just jump in and really speak to the clinical context as to some of the things that you see patients and caregivers experience based on confirming a diagnosis with spirometry.
Thanks so much, Gracia. So as identified, spirometry testing is the only clinical way to diagnose COPD. It is a common and effective breathing test where you can access in both primary care provider settings, so your doctor or nurse practitioner's office, or in a hospital-based setting where you would have a pulmonary function test or a spirometry test done there. The earlier the test is done, the earlier that lung disease is detected and treated. There are many treatments available to reduce symptoms to prevent lung disease from becoming worse, and therefore we can reduce exacerbations, flare-ups, and improve day-to-day living. There are about 2 million people in Canada diagnosed with COPD, with an estimated 1 million more living with it and not yet diagnosed. Why that is, there's a lot of stigma around COPD. A lot of people are afraid to go to their doctor's office or afraid to have testing done because they have a history of smoking. They are afraid to learn the results. They are afraid to be shamed for their smoking history, and not aware that there's a support available to them. Support with smoking cessation, support with addictions, etc. A lot of people don't come to office with symptoms until those symptoms are moderately to severely impacting their everyday activities. So people with mild, infrequent symptoms often attribute their symptoms to aging, deconditioning, their smoker's cough, and don't think of it as this could be something more like COPD. Often people with COPD have other comorbidities. So a lot of symptoms overlap, like cardiac disease. So people with breathlessness, chest discomfort, and so they attribute their symptoms to those other underlying comorbidities and not to something more. One of the other reasons why spirometry is not well utilized is access. There is a significant population in the province that do not have a primary care provider. The spirometry tests or the centers for testing require an order for the test to be done. Someone has to order it. So without a primary care provider, this is a big limiting factor for people to have the test done and to be diagnosed, and therefore that cycle that comes with it. Who's going to prescribe the medications, who's going to manage them, who's going to do referrals to specialists or other allied health that could help support. Other things to access to the test centers is also a barrier, especially in rural areas. There are not a lot of testing centers, or there's transportation barriers to get to these centers or other limiting factors. There are long wait times for testing in a lot of different centers as well. So it'd be great if we had more funding to open more test centers so that we can help better support the people living with symptoms. On the flip side, there's a lot of patients who have been overdiagnosed with COPD based on their clinical presentation. They present with cough, productive cough, shortness of breath, history of smoking, or their chest x-ray shows hyperinflation, these big long lungs on chest x-ray, which often can indicate that there is inflammatory lung disease like COPD, but it could also represent asthma or something else. So we can't clinically diagnose off of a chest x-ray or a CT scan Again, we can only make an official diagnosis with spirometry. And so patients present with those symptoms, they're assumed to have COPD. They are started on puffers early or wherever they are with their course projection. And so they could be misdiagnosed and on medications that could have adverse side effects as well. If patients present in exacerbation stage where they have severe symptoms, breathlessness, productive cough, fever, etc., again, assumption that this is an exacerbation of the symptoms. Treatment is, if not already initiated, it is stepped up, and they often end up on triple therapy, which again, or high doses of oral steroids or antibiotics, which again can increase the risks of adverse side effects if it wasn't needed. So a lot of things to consider with spirometry and making an official diagnosis. So I hope I
Thank you
covered
so much.
everything there.
Yes, you covered that was very comprehensive. Thank you for covering all those points, which are really important for confirming a diagnosis, but there are also system barriers that we are aware of and some difficulties that patients and caregivers experience in the province. And so we know that having a confirmed diagnosis is really important for the next statement that we'll speak to, pharmacological management of stable COPD. So people with a confirmed diagnosis of COPD are offered individualized pharmacotherapy to improve symptoms and prevent acute exacerbations. Their medications are reviewed at least annually. And so we know that medications are an important part of managing COPD. They can really help manage day-to-day symptoms. They can also prevent and manage acute exacerbations of COPD, or what we call flare-ups. And so your healthcare professional or your clinician should really explain how and when to take your medications. If you're using an inhaler, your healthcare professional should ask to show how to use it and make sure that there's confidence in using the inhaler. And so, Ellen, I would like to give you the floor to maybe describe some of the difficulties or things that you've seen come up in your practice related to pharmacological management.
So I've been a respiratory therapist now for 24 years. And when I started, there were very few treatment options available on the market. Over the last several years, the respiratory market has become very competitive. And therefore, there are a lot of treatment options available now for people living with asthma and COPD. And so it makes it very challenging to stay up to date and current on all of the new treatment modalities, how to use them, how many doses are in each of these inhalers. So it becomes a challenge for the day-to-day primary care provider. And let's be real, people are becoming more and more complex. They have more and more health issues, more and more socioeconomic issues that impact their health. And so the healthcare burden that we are experiencing is quite high. So primary care providers, if patients are so lucky to have one, they don't have that same time available to them with their primary care provider to do a comprehensive review of the medications. So that is one of the biggest challenges that I see, is that patients are started on treatment. There's assumptions that the pharmacist will review the inhalers and the device technique, et cetera. But now with pharmacists having increased scopes in their practice, we also then see that there's assumptions that someone else is going to do that education piece. So as a respiratory therapist, certified respiratory educator, I'm very happy to know that I have a great program and a great team available to offer education. But again, not all areas have access to such programs where we can do comprehensive assessments, do this thorough education, review inhaler technique at every single visit. I can't stress that enough. If you're a patient on this webinar or you have a family member, inhaler technique is crucial. 9 out of 10 people don't use their inhaler device adequately, which then can lead critical errors, which can impact the delivery and therefore not give the results that you're expecting. So symptoms are not improved, etc. And so it impacts the quality of life. So it's very important, if there is access to a certified respiratory educator, a lung health education program, that people get referred. There are other things to consider. People should be taught how many doses are in each of those devices, assessing the compliance and adherence. There are once-a-day treatment options, twice a day, multiple times a day options, what's going to work best for that particular patient, because that's something we need to do, is choose the right inhaler for the right patient. There are the single inhaler triple therapies. There's multiple inhaler triple therapies. We know that people do better if it's one device. Multiple devices increases the risk for critical errors. So if possible, speak to your primary care provider about being switched to a simple device that is easy to use and would be something that they'd be more compliant in using. As people age, as Myra has identified, her mother developed dementia or Alzheimer's. And so cognition is something that's really important to be factoring in, choosing the right device for that clientele. There are people with arthritis and have dexterity issues. A lot of inhalers, like a metered dose inhaler with an aero chamber, is complicated for people who have arthritic hands. So choosing the right device for them. Other important things, cost. Not everyone with COPD is over the age of 65 and have ODB coverage. Not everyone has private insurance. Therefore, we have to take that into consideration. And so we have to advocate for Trillium applications, compassionate care coverage if available. So there's lots of things that we as respiratory therapists do behind the scenes to advocate for such services. So I think I'll stop there.
That's amazing. Thank you so much, Ellen. And yes, those are key things that patients and caregivers can really advocate for in their care to ensure that they're getting the support that's needed to know the type of medication they should be taking and how to take them specifically. And for those who want more information on the specific medications within the quality standard, we define a bit more stage approach for pharmacological management if you would like to get more information on that. And so the next quality statement that we'll focus on is on vaccinations, especially as we are approaching flu season. So people with COPD are offered influenza, pneumococcal, and other vaccinations as appropriate. So the flu and other infections like pneumonia, which is a lung infection, can make COPD symptoms worse. And so people with COPD should be offered a flu shot every year. You should also be offered vaccines against pneumonia, COVID-19, whooping cough, if you did not get it when you were a teenager, or shingles, if the person is age 50 years or and older. And caregivers and family members are also encouraged to get the appropriate vaccines to really help protect the person with COPD as well as themselves. And so, Myra, I really want you to talk about some of the key considerations for patients and caregivers when it comes to vaccinations.
So vaccinations are an essential part of the non-pharmacological treatment of COPD. They help prevent infections that can worsen respiratory symptoms that lead to exacerbations and complications that overall reduce quality of life for people living with COPD. Many of these vaccinations are free if you're over the age of 65. However, some of them are not available through ODB. For example, RSV being one of them. Right now, this is the new guide to the market in the last year. It's a single dose vaccine recommended for those over the age of 60, but it only comes with private coverage right now. But it is a perk because it can cause, RSV can cause serious respiratory infections in adults with COPD. It is a common virus that we see in both children and adults. Children can be quite sick with it, but they're less likely to die from it as compared to somebody as an adult living with COPD. So it is a quite serious one. So we want to vaccinate against it if possible, but it does come at a cost. About $250, I think, to $300 for the cost of the RSV vaccine for those not covered. The pneumococcal vaccines for pneumonia protection, variety of different ones available. Prevnar 20 is the new guy on the market, and it's a conjugate vaccine, often given first and then followed sometimes by Pneumovax 23. Again, private insurance coverage, and it is covered for those over the age of 65 by ODB. Flu vaccines offered annually are free for anyone. There are standard doses or high doses for those over the age of 65 or for those at high risk like COPD or others that are immunocompromised. COVID-19 vaccines, again, COVID can exacerbate breathing difficulties and lead to severe outcomes. So we do recommend primary series followed by booster doses for those that are eligible. And again, it's free for everyone. Less commonly, but mentioned in the slide, is the Tdap, the tetanus diphtheria pertussis, and it protects against pertussis, which is whooping cough. It's a one-time dose with a booster every 10 years that is also covered through your regular immunization schedule. So one of the big things that my patients will tell me when I recommend vaccines to help protect them against such viruses is the cost. They can't afford it. Many people are having to choose between eating and heating right now, let alone covering the cost of a vaccine. I have parents that I struggle every year. What do I buy them for Christmas? So my advice to you is give the gift of a vaccine for the person that you don't know what to buy them, because it could save their life. So I think that's what I'm going to summarize this quality standard with.
I like the take-home message. It's really appropriate as we're approaching Christmas.
Oh,
The next, well, sorry,
can I go back 1 second, Gracie?
Go ahead, please.
I also forgot to mention the Shingrix vaccine. So many people don't see the correlation with Shingrix and COPD because shingles that can cause inflammatory disorder. It can weaken people's overall health and put them at risk for exacerbations and long-time recovery from the illness. So it is covered right now for those 65 to 75 until the end of December of this year. Then the eligibility goes down to 65 to 70. Otherwise, it would be covered for any age with private insurance.
Thanks for adding that, Ellen. And so the next quality statement we want to highlight is specialized respiratory care. So people who are confirmed with a diagnosis of COPD are referred to specialized respiratory care when it's clinically indicated and after receiving a comprehensive assessment and being offered treatment in primary care. This consultation occurs in accordance with the urgency of their health status. And so at some point that your clinician may determine the need to see a physician who specializes in lung health. And this is usually a respirologist, but it might also be a general internist or a family physician or nurse practitioner with expertise in lung health. And before the person you're caring for is referred to a lung specialist, the healthcare professional should assess them thoroughly and give medication to help manage symptoms. And so I don't know, Ellen, if you have a couple words to say with respect to referral to specialized respiratory care.
Yeah, so again, our healthcare system is quite burdened. There's been a lot of referrals off to respirologists for a variety of reasons. Some hospitals, it's their automatic pathway that somebody's admitted to hospital gets a referral to see a respirologist. Not every patient with COPD needs to see a respirologist. So my take-home message, who needs to see a respirologist? Those with a diagnosis that's not yet confirmed and we're having a difficult time confirming the diagnosis. Those with severe asthma not responding to treatment and might be eligible for a biologic, they should be referred. Anyone with suspected interstitial lung disease should be referred. A transplant candidate should be referred. People not responding to treatment as we suspect they should, or those that are losing lung volume more rapidly on an annual basis should also be referred to a respirologist. We know that access to respirologists is a challenge. We know that there's excessive wait times to see respirologists. So when we look at specialized respiratory care, again, there's a lot of value in referring to lung health education programs where patients can see a respiratory therapist, certified respiratory educator, because they have more time. Most CREs these days have about an hour or more to spend with the patient to really dive deep into doing that thorough education piece, assessment, reassessment, developing and tailoring self-management plans for patients and setting goals. And so there's a lot of value there. And then reserving our respirologists and specialists or those that really need them, which might help reduce the burden for them.
Thank you so much, Ellen. And those clinical indications are also more defined within the quality standard. So I'd invite anyone who's interested to have a look to go to quality statement within the quality standard to specifically see the clinical indications for referral. And I believe this is the last quality standard we're going to highlight in this presentation on pulmonary rehabilitation. So people with moderate to severe stable COPD are referred to a pulmonary rehabilitation program if they have activity or exercise limitations and breathlessness despite appropriate pharmacological management. And so it is really important for your clinician or for your health that you exercise and stay active. So you can talk with your healthcare professional or your clinician about what kinds of exercise would be good for the person that you're caring for and what medications can really help them stay active. And the clinician can also give information about some local programs on lung health and exercise. And so, Ellen, I don't know if you have some thoughts to share with respect to pulmonary rehabilitation.
Yep. So pulmonary rehabilitation is great. It has a lot of components of the program, from exercise training, breathing techniques, the thorough education, nutritional guidance, psychological support, smoking cessation if applicable. There is so many benefits to it, but there are some barriers. So there's a lot of barriers. Again, access to the programs. There is lack of funding for such programs available to patients. The location distance for patients to access these programs. There is more availability of such programs in urban centers than there is in rural settings. So it's a lot for patients to have to access. Faculty design. There may not be accessibility for a lot of patients to get into these programs if they're coming in with a walker or a wheelchair, et cetera. The cost to the participant is something to be factored here. A lot of the patients are still working and these programs run during the day. So in-person programs are a limiting factor for such clientele. Through COVID, our pulmonary rehab programs had to cease because we weren't offering inpatient programs. So our program was able to develop a virtual platform. So we had a couple of different modalities available to people, but recognizing as well, not everyone has technology at home. Not everyone can afford technology or have access to internet services at home. Not everyone in rural settings has good internet connectivity. And so we help to overcome those barriers by by offering tablets with preloaded materials on the tablet that had all the exercise pieces with the educational components as well. And then we had a health coach assigned to these clients every 2 weeks to follow up. Again, this is something that our program was innovative in doing and showed some equally good outcomes as compared to our previous in-person programs. But we know that there's consequences of both, benefits of both, and the social piece that you wouldn't get with the virtual, though. Being in person offers that emotional support, the peer support, and giving purpose. One of the other barriers, people who are moderate to severe, recently admitted to hospital, are the ones that really should be referred to pulmonary rehab programs, but wait times and access is the limiting factor. So by the time they get into the program, they are that much further deconditioned and declining and at risk for additional exacerbations. And so those are some of the challenges that we face, is trying to get people through the program in a timely fashion, but we're only, partially funded for such a program as well. So there's a lot of work that we can do to promote the need for pulmonary rehab.
Thank you so much, Ellen, for that perspective. And just with respect to access and availability of programs, one program we wanted to highlight as a resource today is the Fitness for Breath program by the Lung Health Foundation, which really aims to support people living with chronic lung conditions such as COPD through their Fitness for Breath program, basically focused on the importance of staying active for life, increasing knowledge of fundamental movement skills, and also highlighting health-related benefits of suitable exercise. And so there is a QR code that you can access to the Lung Health Foundation website, which allows you to sign up when I think there were times that were supposed to open up for December, but I would encourage everyone to have a look at this and see if it's something that would be of interest for the person that you're caring for. And an additional resource that I spoke to earlier at a high level is the COPD patient guide, which really makes it easier for clinicians to point patients to resources that can help them with managing their condition. And so it's really a plain language summary of the quality standard, and it has a select list of resources from trusted sources, like the Lung Health Foundation, with specific resources to support people with COPD as well as their caregivers. And so I would also encourage you to check out the patient guide. And in the next section, Julie will now be speaking about the implementation work and the toolkit that encompasses some of these resources that we've highlighted today. So Julie, over to you.
Thanks, Gracia, Myra, and Ellen. Amazing work. I won't spend a whole lot of time here because we'd like to save some time for discussion, recognizing we're a little bit behind. But just wanting to let you know that given the burden on patients and the healthcare system, we, over the last 12 to 16 months, started working more on implementing this quality standard with 12 Ontario health teams across the province. Based on the gaps and barriers that Ellen spoke to and that were identified by both those teams and in developing the quality standard, we highlighted 3 key priorities for action, noting that significant gaps were seen, which Ellen has talked to eloquently: diagnosis, access to specialized care, and pulmonary rehab. We can move to the next slide. So in light of this, we developed a quality standard pathway, not to be confused with the clinical pathway, and an implementation toolkit to go alongside. In it, there are tools and resources, a couple of which have been mentioned already and just recently by Gracia. Resources for both patients, caregivers, and clinicians to assist in implementing each quality statement. And it's also a nudge to consider how the ideas in the toolkit might generate and implement ideas for system and local change. Marnie will add that link to the resource in the chat, but exciting news is that I've been working closely with the Lung Health Foundation this last year and a bit, developing a second version of the toolkit will address all 14 quality statements with an expected release in January, and it's to be more interactive than didactic. And that's it for me. Next slide is really, I'm going to hand it back to Gracia to close this off.
Thank you so much, Julie, and thank you, everyone. Myra, thank you, Ellen, as well. So this concludes our formal presentation, and thank you so much to all for joining us today. If you have any questions with respect to the COPD quality standard or anything we shared today, please feel free to email us at qualitystandards@ontariohealth.ca. And now I will hand it over to Katie to lead us through the Q&A section.
Wonderful. Thanks, Gracia, and all of our panelists today for sharing some really helpful and wonderful information. But a couple questions come through the chat, and before we get to those, I'll just take this opportunity to remind everyone that the recording, the slides, and all of the tools and resources will come to your inbox, folks. So keep an eye on that over the next few days. So we had a couple questions pop in that I'll address first, and certainly if there are others, people can put those in the chat and we'll do our best to get to them. One in this, I might point this to you, Ellen, to kick things off, is around the RSV vaccination and eligibility criteria. There was a question around, is there a known timeline for expansion on the eligibility of the RSV? I'm assuming they mean vaccine. The cost is quite prohibitive.
Not that I'm aware of at this point. I know that the medical specialist liaison and my pharmaceutical reps keep advising that they're lobbying for lowering the age limit and eligibility, but there's been nothing that I've been made aware of. I am with GSK today at an event, and so if I hear anything more as our education day goes on, I will be sure to share it, that we can put it out with the slide deck later.
That's great. Thanks so much. There were a couple questions around the financial limitations. I don't know if there are any tips or strategies either from Ellen or Myra or folks that might have encountered this. Are there any secret workarounds? Are there any tips that we can offer folks around some of the financial limitations for those pieces?
Is it related to vaccines or related to medications? Sorry, I missed.
Well, that's a great clarification. So, drug coverage, vaccines. So we just had a comment in the chat around our drug coverage through certain providers. So I'm sure there's a lot of layers related to medical or additional costs in COPD. So do you have any tips for folks around navigating some of that?
For sure. So some of the pharmaceutical companies do have compassionate care programs. So with the primary care provider, they can apply for sample medication, which can cover them usually 3 months at a time, up to most of them 1 year max. There is some workarounds with that, but limited to about a year. Pharmaceutical companies are really good to give samples of their medications as well. So if you have a primary care provider who's willing to see these reps to get samples in the office, they can be handed out, distributed to those who can't cover the cost of them. But knowing that samples are not a guarantee, that they do have only so many of those available. So we can't rely solely on samples. I hate to say it that sometimes we do have primary care providers who will choose a medication that may not be their first choice for the patient, but recognizing that they're prescribing or sampling based on what's available at the time for them. Trillium is a great application program that they could apply for subsidized coverage. So they would have to pay their quarterly premiums based on income. They have to provide their financial statement or T4, or I forget how it works, but the pharmacists work very closely with them to do Trillium applications or system navigators if you have those available at your primary care team offices. As far as vaccination coverage, I'm not privy to anything with any special information on that other than asking for families to help support the cost by giving the gift of a vaccine. If I do hear of any hidden secrets about it, I will be sure to share that information as well. But to date, I am not aware of any. And again, I do appreciate that people are in a financial crisis right now. And so I would recommend, if they have to choose the ones that are available to them free. And then we would prioritize what's more important based on their history of exacerbations. If they are somebody who recurrently gets pneumonias, then I would say, let's get pneumonia vaccine so for better protection, and then kind of prioritize from there.
Great. Thanks so much. And I love the tip or strategy around gifting this, especially as we enter the holiday season, because it's not always accessible for folks. We had a question, sort of two questions around this, and around the standards referring to advanced care planning and palliative care. The first thought is, do any of our panelists have any further comment around sort of that advanced care planning or palliative care side of this experience? And I might also invite Myra to share. I see Ellen's unmuted, so I'll start with you. And then Myra, I don't know if you have any comments around some of that, if you're comfortable sharing from the caregiver side, navigating some of that process. So maybe Ellen, I'll start with you and then shift over.
So as an RT working in the community setting, we have really close working relationships with Ontario Health at Home. They accept referrals from us as respiratory therapists. There's no barrier to us referring to them for what we call a palliative care approach. So when we have a client with COPD whose condition is changing, their need for supports is increasing, we make referrals to Ontario Health at Home for a palliative care approach. The team come in and assess the patient, looking at what is their PPS score, what are their current needs. They put in the services needed at that moment. And then once the referral is open, supports can be increased as they go along and as the client's condition changes. So that is great news for respiratory therapists if you're on the line, knowing that that's not a barrier. You have to make a recommendation to the primary care provider to then put in a referral. You can do it right then and there while you have the patient in the office and have that opportunity to have that discussion with patients. We talk a lot about palliative care, COPD. There is no cure. It is a palliative condition. So we talk about that at the early onset of the diagnosis so that we can help them plan for the best, prepare for the rest. And so we do talk about that. We do offer advanced care planning workshops for patients, referring them to people who have support groups on palliative care. So lots of resources available for patients in Ontario with Ontario Health at Home and other palliative care teams.
Thanks, Ellen. Before I turn it to you, Myra, I just want to clarify for folks, Ontario Health at Home used to be Home and Community Care Support Services, and before that was the LHIN, and before that was CCAC. So we'll have a range of caregiving experience with a range of understanding of what we mean by Ontario Health at Home. So that's what we're referring to. Myra, did you have any comments or thoughts around that side of your experience that you're comfortable sharing?
Just a few. I've learned a lot in this webinar and listening to Ellen, because our primary our attention was mostly focused on my mom's Alzheimer's. Now, right at the very end of her life, we were noticing her having more challenges breathing, and it was it was always scary to see. It was scary, like watching her chest go up and down. And I remember on her last night at home, she was like, I can't get my breath. I can't get my breath. And so making the decision about, do we call 911? Do I take her to the hospital myself, or do we just breathe through it and wait till morning to call her family doctor? And we ended up doing that. But I was doing that all based on instinct, really, and paying attention to my mom, as opposed to really having a good understanding about what to pay attention to with COPD and how that impacted her overall health. So I'm having lots of reflection about, if I'd known that. But she did get good care, and all was relatively good in our situation, but there's lots of learning today for me.
Thanks, Myra. And it does reflect the common experience of caregivers is we don't know what we don't know, and we figure it out as we go. So thanks for sharing that. And I see, Garcia, you've got your hand up. We'll end on your comment there.
Thanks so much, Kitty. Yes, I want to just highlight what Ellen mentioned, and within the COPD quality standard on the statement on palliative care, really highlighting that the need for palliative care can occur as early as the time of diagnosis. And so this support is really includes different domains that are needed by the patient as well as the caregiver and any family member caring for the person as well. And so the support will not just be for the person caring, for the person who has COPD, but also for any support the caregiver may need along the disease trajectory.
Thanks for that. Thanks for clarifying. And a great tip from someone in the chat box. If you do live in a community where there's community paramedicine programs, there are some resources available through them as well. So you can reach out to your local EMS and see if they have a community paramedicine program in your community. We are at 1 o'clock, just over 1 o'clock. So I want to thank you, Myra, for sharing your personal experience with us, your experience with your mother and COPD and her dementia diagnosis, and to Gracia, Ellen, and Julia for sharing more about the Ontario Health Quality Standards on COPD, and including some great strategies to support someone with COPD and yourself as a caregiver. So many great resources that our audience can view and review as we send out that post webinar email, and hopefully implement along your caregiving experience.